So I will thank, congratulate, and I will do something for you that I will promise. Thank you very much. आवाज नहीं आ रही है.
Sir, you are muted, sir.
My friend Dr. Vijay, who has been a very talented guy, to speak a few words before I introduce Dr. Rajay.
Thank you, Dr. Ajay. Thank you very much.
Sir.
Actually, you have made this session international,
Sir.
because I have seen doctors from UK, doctors from USA, apart from doctors from India, are taking part in this teaching program. It is
Yes,
great.
sir.
I must congratulate you. I must
Sir.
thank you. And
Sir.
I say that we are going towards the end of this session. So we
Yes,
will
sir.
meet again in a better way. Thank you very much. Thank you.
Sir. So Dr. Rajay is very well known to us. He is a son of soil. He is basically from Patna. And जो कहते हैं ना कि बाड़े पूत पिता के वही हैं Dr. Rajay, son of Dr. Mahendra Narayan, the great legendary physician of our state and our area. And people know him in medicine. Who doesn't know him in medicine? And Dr. Rajay went to England, and he has many laurels in his book. And after MRCP and all, he's working in Guy's Hospital as well, and doing a lot of research activity, a lot of community activity, and the first guy to start cardio-metabolic clinic in London. So that is phenomenal. And I requested him, Rajay, do something for the community. And the community is MD students from all over India. And he has kindly agreed to do that. And today's topic is very special. Today's topic is very special because nothing is more important than cardio-metabolic syndrome. This perspective has come up in a new way. So, and he is leading the sphere. He is leading the concept, not only in England, across the world, across the whole Europe. And his vision is to start this project. And we will also promise we'll give our contribution, whatever he likes. And youngsters are going to get benefited by his lecture. And I would request that, they should come out with the questions, as many as possible. So, Vijay, would you like to say a few words? Vijay? Vijay would like to have few words, or else we will start. You can speak later on. So Rajay, over to you. You are mute. Rajay, you are mute.
Thank you so much, Dr. Sinha. Can you hear me?
Yes.
Perfect. So thank you so much for the invitation, and I'm grateful to the Association of Physicians of India for giving me this opportunity to be present here for this exciting session on cardio-renal metabolic. Dr. Sinha suggested that we have got MD-PG students who are part of this certificate course from the API, and I'm very excited to be part of this certificate course and to be part of this faculty for this fantastic course that you are running in India. We'll be very happy to be collaborate in future as well. So just to introduce myself, I am Rajan Narayan. I'm a heart failure cardiologist at St. George's University Hospital in London. But interestingly, God has been kind that we managed to set up UK's first cardio metabolic clinic in the NHS in September 2020 in the middle of the pandemic. In fact, in the last 3 years, with the exciting result that we had, we submitted the report to the government, and we have now become the first center in the country to set up the cardio-renal metabolic clinic. So what that means, that we have a heart failure specialist, a nephrologist, and endocrinologist seeing all complex patients with heart, kidney, diabetes, obesity, lipid, all in one setting. Something like this at the moment does not exist anywhere in the Europe, not only in UK, but not in Europe either. So again, we are very lucky that we have now set up a cardio renal metabolic clinic. The initial cardiometabolic clinic that we had set up, that is also running. We now have got 4 months waiting list to see patients, because we know that this is one of the biggest challenges that we are going to face in healthcare, as a doctor, as a physician, as a nurse, as a pharmacist. So all healthcare professionals around the world are going to see this problem in the coming weeks and months ahead of us. So the reason we started the cardiometabolic clinic in the first instance in September 2020 was because we were seeing already a lot of patients with heart disease, diabetes, kidney disease. In fact, now there is more research to suggest that it's a cardio-renal metabolic syndrome or a cardiometabolic syndrome. But in 10 years before from now, we were not aware that cardio-renal metabolic is so closely associated to each other. Obviously, there's more research now to suggest that. And we possibly saw something coming in our way, because we were seeing many heart failure patients coming with a lot of complications. And that's why we started the cardiometabolic clinic. So this is the global burden disease data. This sits with Salim Yusuf in Canada. He is the author, the main person, the founder for the global burden disease. It sits with him. So he's got database from 193 countries, and this talks about the causes of death globally. And this is where we are in the middle of somewhere here. If you look at the causes of death, heart disease, stroke will be in the top few causes of death. But more interestingly, diabetes is around 15, 16, 17 in different parts of the world. But see what happens in 20 years' time. Heart disease is still number one, stroke is still number two, but diabetes will jump from 15 to number 7. CKD will jump even further up to number 5. So again, majority of the countries, we are likely to see heart, kidney, diabetes in the top 5, 10 killers at a global level as an average. And that includes UK, Europe, or be India. But more importantly, post-pandemic, WHO has now come up with a report which is called the Pulse Survey. And the Pulse Survey says that in almost 90% countries of the world, and that includes us in Europe and some parts of India as well, 90% countries of the world are likely to miss their targets in non-communicable disease diagnosis and treatment by up to 70%. So whatever the targets that I have set up in UK or the government of UK has set up for our patients in the UK, we are likely to miss 70% of those targets in the next 5 years, because we are not screening them enough. We are not optimizing their medication. And that is where it is extremely, extremely important to manage these patients holistically, because it's not just heart. Look at some of the numbers. Till recently, we thought that number of heart failure patients globally are around 25-30 million. But Salim Yusuf presented a paper at ESC last year suggesting that the number of patients with heart failure globally sits around 64 million and plus. So double the number of patients of heart failure that we thought that exists in the world. This is where we thought that in 2024, 2025, we'll have possibly around 530, 550 million patients with diabetes. And I'll show you the current number in a second. Similarly, with hypercholesteremia, about 30 million patients with hypercholesteremia. Renal patients, almost 10% of world's population has got chronic kidney disease. More than 850 million patients have got some degree of chronic kidney disease. So again, a big challenge that we have to face and encounter and to treat in the coming months and years. But if you look at the causes of death globally, majority of the deaths in the green are because of non-communicable diseases. And this is again across the board. So looking at some of the epidemiology of the heart failure, as I already mentioned, that the number of patients around 64 million, almost 1 to 3% of general adult population suffer from heart failure. 1 to 20 cases per 1,000 cases exist globally. 30%, 30-day mortality can be anywhere between 3 to 5%. 1-year mortality can be up to 30%. 3-year mortality can be up to 50%. In fact, majority of the studies now show that all heart failure patients that you're going to see today, 50% of those patients will be dead in 5 years' time, because we are not doing enough. We need to optimize more. If you look at some of the statistics from UK, from the Office of National Statistics and the NICOR database, only 37% patients with heart failure, they get the four pillars for heart failure. So we know that beta blocker, ACE inhibitors, MRA, SGLT2 are the four pillars for heart failure. But only 37% patients in the UK get four pillars because again, there is health equity problems, availability of the drugs, confidence of the general practitioners in the GP in the primary care world. So again, there are a variety of reasons why a lot of patients still do not get the right treatment. And in fact, obviously, we know that this costs lots and lots of money, thousands and millions of pounds across the globe, depending on which part of the world you live. So again, these are some of the statistics from different parts of the world. India and those part of Russia and those part of the world in Asia are in blue because we don't have enough data from many of those countries, and that includes India, unfortunately, as well. Cardiovascular disease, we know, is one of the biggest problems in India. But again, when it comes to heart failure, the registry, the database is not up to standard or not up to the mark. We don't have exact number of deaths coming from cardiovascular disease or heart failure. So again, we need to really work a lot on databasing these patients with heart failure, especially in India. Looking at some of the numbers, 7.8 million patients are likely to die from cardiovascular disease in 2025. 620 million cardiovascular disease patients were recorded in 2023. So again, heart disease, we know, is one of the biggest killer globally. Looking at prevalence in India, 1/5 of heart disease around the world are from the Indian subcontinent. So again, it is exciting and to see that there is some data coming, but again, more work is required. Surprisingly, states like Kerala, Punjab, and Tamil Nadu have got highest number of CVD and high cholesterol numbers. So again, some of the database, some of the papers which have been published from India, Kerala, Punjab, and Tamil Nadu, they are, in fact, in spite of the fact that we know that there's 100% literacy in Kerala and possibly people are aware what to eat, what not to eat. But Kerala is again one of the top 3 states in India where heart disease is extremely prevalent. These are some of the numbers, again, global numbers that have been reported in some of the studies suggesting that likely that we have up to about 5 million patients with cardiovascular disease living in India. Looking at diabetes numbers, this is what I was saying, that we thought that in 2025 we will have about 750, 770. Again, different studies quoted different some numbers, but we are looking at somewhere around the population for diabetes should have been around 540 million in 2025. So again, this is 2045 that you are likely to hit 783 million. But if we go back in time and if we are in somewhere in between 2021 and 2030, that is 2025, we are likely to be having patients around 540, 550 million patients, and that is across low and middle income countries, high income countries, and that is again present in most of the report that studies that talk about diabetes. So this is what we should be having at the moment, around 550 million. Couple of months ago, there was the World Diabetes Day, and WHO has published the paper and the figures that we have already hit 800 million. We were supposed to hit that number in 2055. 25 years, 30 years ahead of our time. We have already reached 800 million patients with diabetes. So that is the number of patients that we are talking about globally. Prevalence of diabetes in India is extremely high. It's about 100 million at the moment. It is likely to go up. In fact, we are likely to see almost about 68% increase in diabetes population in India. And that is the prediction from the WHO, from the UNICEF, and all the papers which have been published internationally, globally, related to diabetes numbers in India. So again, as I said, that we are almost about 101 million or 100 million in some of those papers. And this is again rising because we know that India is sometimes referred to as the diabetes capital of the world because we've got huge number of patients. As I said earlier, CKD, huge numbers because we know that if you have more diabetes, you're more likely to get chronic kidney disease. So the numbers are sitting around 850 million, almost 10% of world's population has got some degree of CKD. When it comes to India, unfortunately, there is vague distribution of numbers in different studies. Some studies suggest 2, 3, 4%. Some studies have suggested up to 30% of India's population has got some degree of CKD. So again, there is no fixed data that you can find when it comes to CKD in India. But again, on an average, it sits anywhere between 10 to 30% across different states. CVD will be the main cause of death. Again, if you look at the registry from around the world, whether it be UK, Europe, US, Asia, and that includes India, cardiovascular disease will be the main cause of death in heart failure. This is again a NICOR database from the Office of National Statistics in the UK, which says that in hospital mortality can be up to 10%, 30-day post-discharge mortality can be 6%, and 1-year mortality in heart failure patients post-discharge can be up to 25%. So again, these are very high-risk patients. Some of the studies in heart failure have now suggested that heart failure patients are likely to have at least 3 or more comorbidities in majority of the heart failure patients. So again, if they look at the cohort of heart failure patients, up to 70, 75, in some studies up to 80% of the patients have got at least 3 or more comorbidities, and that is how it becomes very challenging to manage these patients. And this is the reason why, because once a metabolic disease process syndrome kicks in, there is hyperglycemia, there is insulin resistance, there is sympathetic nervous system activation, RAS activation, increased stress, increased inflammation, and that affects your heart. It leads to myocardial disorders, systolic diastolic dysfunction, LVH, hypertrophy, calcification, and it also affects the kidney at the same time because there's increased hyperfiltration, hypertension in the kidneys. The TGF feedback mechanism gets disrupted. So again, if one organ gets defected, it affects the other, and then that is how they kind of lead to a cardiorenal metabolic syndrome, because one problem leads to other and the other leads to the others, and that is how the cardiorenal metabolic axis and the problem really exists in the real world scenario. So when it comes to diagnosis of heart failure, this is what the ESC guidelines say, that we should be doing more blood tests in the community like BNP or anti-proBNP, 12-lead ECGs, echocardiogram. Obviously, echo is not available in the primary care in the GP population. They can still do a chest X-ray, but again, the gold standard that we should be using more and more is BNP or anti-proBNP, whatever is available, because that is how you will be able to pick up these patients early with heart failure. When it comes to ACC, again, it has got a very vague way of classifying heart failure with risk, patient at risk of heart failure, pre-heart failure, symptomatic heart failure. But again, the bottom line is that if you suspect a patient who comes with shortness of breath or waking up early or crackles, edema in the legs, all those clinical signs that we should be looking at heart failure, then BNP is an important blood test that you should be doing as a first point of test to pick up these patients early. The NICE guideline, the National Institute of Clinical Excellence guidelines in the UK, says that if your BNP is more than 2000, these patients need to be referred to the hospital, to the secondary care, to the specialists, to the experts within the first 2 weeks, while you're trying to optimize their medication, because you've already picked up somebody who's got heart failure with BNP of more than 2000. They need to be referred to a heart failure cardiologist within 2 weeks. If it is between 400 and 2000, they need to be seen in 6 weeks time, but again, they have to be seen within the 6 weeks period. And obviously, once they are diagnosed, they have to be optimized on the 4 pillars, because that is how you manage these patients. That is how we can get better long-term outcome. This is how ESC now defines the heart failure with reduced ejection fraction less than 40%. Between 40 to 49 is mid-range ejection fraction, and more than 50 is heart failure with preserved ejection fraction, as we know. This is what we knew as medical students, as junior doctors, because what the understanding of heart failure was systolic heart failure. So we knew that there is stretched walls, there's dilated chambers, the pumping of the heart is weak, the heart is not able to contract properly. But this is what we have learned more and more and more now. This is heart failure with preserved ejection fraction or diastolic heart failure. So who are these patients? Patients with ischemic heart disease, hypertension, diabetes, chronic kidney disease, atrial fibrillation, sleep apnea. These are the patients who are likely to get stiff heart. They are likely to get thickened chambers. So as you can see that this chamber of the heart, LVH, there is increased LVH, increased fibrosis. So the heart cannot relax during diastole because there is stiffness, there is thickness in the heart muscle. And this is heart failure with preserved ejection fraction. When I was a medical student, we knew that if you have got diabetes, you're likely to get blockage in your heart arteries, and that's coronary artery disease is more common in patients with diabetes. But now, heart failure is the first presentation related to heart in diabetes across the world. So coronary artery disease has been now taken over by heart failure, because heart failure is the first presentation that you get in patients with diabetes, which is related to heart. So always when you're looking at the echocardiogram, you should definitely obviously look at the systolic function of the heart, but more importantly, look at signs for diastolic heart failure. So increased LA size, signs that tell you that there is diastology dysfunction in the heart. So again, all those things have to be looked at, because early pickup of these patients, early initiation of all those 4 pillars is extremely important for long-term outcome in these patients. Because as I said, that majority of these patients are likely to die in 5 years' time if you don't pick them up early. So again, these are some important risk factors, and I'm sure you all know about this. We have mentioned this: smoking, excessive alcohol, sedentary lifestyle, coronary artery disease, hypertension, diabetes, some important risk factors to keep in mind. Because again, these are some of those patients that we see on our day-to-day clinical practice who are likely to get heart failure, and especially diastolic heart failure, which should be picked up early in these patients. So dyspnea, fatigue, trouble sleeping. The first symptom that patients with heart failure present is they keep waking up early in the morning. So again, trouble in sleeping, nocturnal cough, loss of appetite. So those can be very, very vague symptoms that they normally start with, and obviously as time progresses, they develop dyspnea, fatigue, intolerance, cardiac murmur, ascites, swelling, ankle edema. And I'm sure you're all aware of some of those symptoms that we're talking about. These are some of the tests that we should be doing in these patients the moment we think that these patients have got heart failure. Apart from BNP, renal function, thyroid, liver function, lipid profile, iron, because we know there is role for IV iron now, because it is one of the guidelines from the European Society of Cardiology that patients with low transferrin saturation, low ferritin, they are suitable for IV iron if their ejection fraction is less than 35%. So again, some of the important blood tests that should be considered in these patients with heart failure, because that will again help you to understand the underlying etiology for the heart failure. So again, we have already discussed this, that more than 2000 urgent referral, between 400 to 2000, they have to be seen in 6 weeks time. Less than 400, and in fact less than 35 heart failure is very, very unlikely. Then you have to think of some other etiology for their shortness of breath. We know that BNP is a myocardial stretch marker, so it downregulates the sympathetic system, causes diuresis, increases peripheral resistance. So again, just like any of those inflammatory markers, just like TROP-T, this is also like an inflammatory response. So again, you may see increase in BNP in many of other conditions apart from heart failure. So again, a very important clinical correlation is important, but obviously if you get big numbers, then we have the heart failure is more and more likely, especially more than 2000. These are some of the findings that you may find in a patient with heart failure, which can include atrial arrhythmias, atrial fibrillation, left bundle branch block, frequent preventricular contractions. So again, some of those hints that you may see on an ECG that may tell you that this person has got underlying etiology of heart failure. Again, it could be coronary artery disease or AF or arrhythmia that can lead to heart failure. Imaging in heart failure is extremely important. This is again chest X-ray showing patients with pulmonary edema, and offloading. After offloading, you can see how the chest X-ray becomes nice, black and clear. Echo is again gold standard. We all know that. We use it for LV wall thickness, LV volume, LV mass, 3D measurements, myocardial strain. So we are doing lots of other measurements that we used to do before, functional MR, LV dysynchrony. So all those signs that we should be looking in an echocardiogram that will again help us to diagnose the type of heart failure and again the etiology for heart failure. So this is a very nice picture to show on the left how a nice contracting healthy heart looks like, and on the right you can see that the slow sluggish heart which is not contracting well, possibly ejection fraction around 20-25% on that picture. But there is more evolution. In the UK, in the last 6 months, the National Institute of Clinical Excellence has now given clearance to this device, which is called the V-scan. It's a handheld ultrasound which can be used by anybody with no prior experience of echocardiogram. You put this probe on the patient's chest, you connect it through Wi-Fi on your phone, and through artificial intelligence, within 30 seconds, it calculates your ejection fraction. This is extremely, extremely helpful, especially in the primary care when there is a long waiting list to get an echocardiogram done. It helps you to look at the heart, the atria, the ventricle, the pulmonary artery, IVC. It also tells you about pericardial and pleural effusion. So again, there's some basic measurements that you can do in the community. And this again has become a very good practice, a very important practice in the community for heart failure. This is the V-scan. As you can see the picture, you can put the patients in a subcostal view or four-chamber view. You get all these views, which again will help you to diagnose heart failure early in the community. So again, a simple, small handheld device that can be used now in the community, and you don't have to have a full echocardiogram picture done. So, but MRI again is, we know that we are gold standard. These are some of the areas of MRI that we saw that is of interest to us, because that is where we look for hypertrophy, for GAD enhancement, for GAD uptake. This is your LV, this is your RV, and I'm sure you're all aware of these different areas and measurements that we look in MRI. Again, some interesting pictures, whether it be hypertensive cardiomyopathy, looking at the LVH, looking at hypertrophic cardiomyopathy with SAM and mitral regurgitation jet with Fabry's disease or cardiac amyloid. Again, different pictures, different kinds of uptake, different kinds of gadolinium that you will see, the distribution of the GAD all helps you to diagnose whether this patient has cardiac amyloid or cardiac sarcoid as an underlying etiology. So looking at again some of those cases that we have seen, very interesting cases. This is a picture from a patient from Fabry's disease, and you can see that there's mid myocardial enhanced in the basal introlateral segment and extending into the basal anterolateral segment. So again, very interesting uptake of GAD in some of those segments. In Fabry's disease, we have picked up at least 3 patients with Fabry's recently. This is again a picture of a patient from hypertrophic cardiomyopathy in a 44-year-old woman with obstructive hypertrophic cardiomyopathy. As you can see that there is elongated anterior mitral valve. So SAM movement with extensive jet of MR that you can see on a live picture. So again, very helpful when it comes to diagnosing the underlying etiology with LVH. Looking at cardiac sarcoid, you can again see a T2 image here where you can see interventricular septum, a varied degree of GAD enhancement that was seen through signal imaging. Looking again some of those pictures for amyloid, because amyloid, we have seen huge number of patients with amyloid. We've got a big population of black ethnicity in our area, so we do see patients with amyloid from time to time. This is a patient with pleural effusion. He had pericardial effusion as well. There was late GAD enhancement, and more importantly, there was diffuse global subendocardial enhancement. As you can see, there is diffuse subendocardial enhancement in the MRI, and that again gives you a hint that this could be an underlying amyloid, which is the etiology for this patient. But again, you have to be a bit more experienced. You have to do more and more. We normally say that you do at least 200 MRIs before you become good at it. This is another patient with LVH with 14 millimeter and acute anteroseptal bulge with outflow tract obstruction. As you can see, there's obstruction in the outflow tract with a bulge there in the anteroseptal angle. And this is like a patient with hypertensive cardiomyopathy. So again, as when it comes to management and pharmacological management of heart failure, especially, things have changed drastically. When we were in medical school as a junior doctor, this is what we knew, that ACE inhibitors, beta blockers are the drugs that have to be used. As time progressed in 2005, device therapy came in, and then obviously ivabradine came in, eplerenone came in 2010. So again, as time progressed, more and more drugs started coming in. And obviously, this is again starting from one therapy to two to triple. And obviously now, as we know that there are 4 therapies, there are the 4 pillars for heart failure. With increasing time, Paragon HF with the Entresto, the sacubitril valsartan, dapagliflozin, empagliflozin, all those drugs with evidence on heart failure, CKD has come with an SGLT2. Now that is the gold standard, the 4 pillars for heart failure. So ARNI, beta blocker, MRA, SGLT2, we are doing this more and more. So again, especially in young patients who have got good blood pressure, especially in post-MI young patients, patients who can tolerate the drug with good blood pressure, we just straight away start them on RD. We don't need to go on ACE inhibitors. So again, trying to optimize all those 4 pillars as early as possible. SGLT2 is now the established 4th pillar for heart failure. SGLT2 is a fantastic drug. There is variety of mode of action, but this is the most understandable mechanism of action, because we know that there is proximal tubule in the kidney, and the work of proximal tubule is to try and absorb glucose, try and absorb energy for your body. So again, it has got a protective mechanism in the proximal tubule. But the moment you block this SGLT2 with a receptor, which is a dapagliflozin or empagliflozin, this is what happens. Instead of the glucose getting absorbed in the proximal tubule, you lose glucose. With losing glucose, there is a loss of little bit of fluid, which is osmotic diuresis. And with every amount of fluid that you lose, there is up to 10% reduction in body weight, although it is not a drug that can be used for weight reduction. But in some studies, at least 5, 7, 10% weight reduction was seen. And with every 10% reduction seen in the weight, there is reduction of MACE, hospitalization, non-fatal MI, stroke, CV death by up to 21%. Not only that, in majority of the SGLT2 studies, there was 3 to 4 to 5 millimeter drop in the blood pressure. And with every 10 millimeter drop in the blood pressure, we know that the CV event, heart disease, stroke, heart failure, they go down up to 30%. So again, a fantastic drug, which should definitely be one of your 4 pillars when you're treating patients with heart failure. Coming to RAS inhibition, we are doing this, as I said, that this is something gold standard. We have been doing this for decades and decades. It's a fantastic drug. It works fantastically well, especially ARNI, I would say sacubitril valsartan that we have been using in the UK. I've had dozens of patients where the ejection fraction has sat between 30 to 35% 3 months down the line with an ACE inhibitor. The moment you change them to sacubitril valsartan, in a month's time, their ejection fraction is above 35%, and then they don't need a device, because NICE says that after 3 months, you have to assess patients whether they need a device or not, because that depends on your ejection fraction. So you have to reassess their echo, look at their echo in 3 months' time. If less than 35%, then they have to be referred to an ICE for an ICT or CRT, depending on their ECG and various other markers. Beta blocker, again, we have been using for a long time. It provides fantastic inotropic support, helps maintaining your cardiac output. MRA is something that we are using more and more. My strategy in heart failure, majority of the heart failure patients, especially elderly patients, is that if they are 75 plus with multiple comorbidities, they have low blood pressure, it becomes challenging. And I see in almost 20-30% of those patients that if you start a drug like eplerenone or spironolactone, their blood pressure drops down. When the blood pressure drops down, it affects your kidney function. The kidney function goes down, and you end up stopping the rest of the drugs as well, because your blood pressure is very low. So what I do as a standard, and what we do as a standard in the department now, that we bring in our ARNI, we bring in our beta blocker, but the third drug that we bring on board is always an SGLT2, because we know SGLT2 has got license in CKD. It stabilizes your kidney function, and once your kidney function is stabilized, then we bring a small dose of spironolactone, like 12.5 milligram, and that way the patients are able to tolerate the drug better. But now we also have got finerenone, because again there was indication in non-diabetic CKD, pediatric CKD, CKD associated with diabetes, but we have now got an indication to be used in diabetic heart failure patients. Again, we are using more and more of finerenone in our day-to-day clinical practice. These are some of the long-term management, again, long-term challenges that we see when we are managing patients with heart failure. So I need help with inotropes, or when you've got patients in their advanced and NYHA class 3, class 4 with high BNP and organ dysfunction, ejection fraction is very low, or they're getting defibrillator shocks, or they're getting more than one hospitalization in 12 months time, increasing edema, low blood pressure. So again, this is a very nice short form that is used in clinical practice by junior doctors in Europe. I need help for heart failure patients, to look at some of those challenges that you see in these patients. So as I said earlier, that when you pick up a patient with heart failure, National Institute of Clinical Excellence says that you should try and optimize the 4 pillars quickly. Once you've optimized the 4 pillars for 3 months, you need to bring the patient back, assess their ejection fraction. If their EF is less than 35%, then and their QRS is less than 130, then they become eligible for an ICD. If their EF is less than 35% with QRS more than 130, then again, depending on some of the other criteria, which I'll show in a second, they become eligible for a CRTD. So again, we are referring many of these patients for device therapy. But as I said earlier, that using Entresto in some of these patients has really helped me to stop those patients from having a device. So again, these are some of the situations where you will consider a CRTP rather than a CRTD. So non-ischemic cardiomyopathy, short life expectancy, major comorbidities, poor renal function, patient preference when they don't want to have an unnecessary shock from an ICD. So again, those are some of the situations where you will go for a CRTP rather than a CRTD, which is the defibrillator part of the CRT. So again, depending on your ejection fraction and ECG, that you will decide on that. This is a very nice picture to show an ICD on a chest X-ray and a CRTD with the 3 leads on a chest X-ray. Looking at, again, a very interesting case from a CRT responder who had a cardiothoracic ratio of 57%, how their CTR ratio kept on improving within few months' time. Their QRS improved from 176 to 138 post CRTD. Their LV ejection fraction improved from 16%, which was here, to 46%. And obviously the heart failure symptoms improved, and you can see a much better CTR ratio, a better looking heart, a better looking overall CTR ratio on this patient who was a very good CRT responder. Looking at heart failure advanced therapies, NICE says that if you have considered all the options for heart failure, the patient is still symptomatic, refractory heart failure symptoms, or in refractory cardiogenic shock, they can be referred for a heart transplant. ESC again has an end-stage heart failure with severe symptoms with poor prognosis, and you are left with no alternative treatment options. You should be referring for heart transplant. Again, these are some of those indications that you should be considering mechanical circulatory support in these patients. These are some of the contraindications where again heart transplant is not possible, especially if you've got end organ damage or poor comorbidity, or the chance of life expectancy because of severe other comorbidities is less than a year. Then obviously they become ineligible for a heart transplant. But we have got patients with heart transplant. Some of them have made it up to 14 years, 13 years, 11 years. So again, the average median survival in these patients is up to 12 and a half to 13, 14 years. But again, there are challenges because there is graft dysfunction, graft rejection, there is problems from the immunosuppression, there is also problems from vasculopathy. There is some cases we have seen patients coming back with malignancy and renal failure. So again, some challenges do exist, but again, patients who do well, they do really well post-transplant. These are some of the situations. Hyperkalemia is one of the most challenging things that we see when we are trying to optimize our patients with four pillars, especially when you're trying to optimize their ARNI, ACE inhibitor, or MRA kind of drugs, because we know that all of these drugs can lead to hyperkalemia. And again, hyperkalemia and more than 6.5 can lead to heart rhythm disturbances, which is not safe in the community. And again, these are seen in patients with heart failure, CKD, and diabetes, especially when you're trying to optimize ARNI, ACE, and MRA in these patients. This is what we normally do. This is the standard treatment with calcium gluconate, insulin dextrose when they come to the hospital. But now we have a better answer. We've got sodium zirconium, which is again Lokelma, which is available by AstraZeneca here in the UK. It's a sachet, it's a powder that you give in 45 mils of water. Can be given up to 10 grams 3 times a day for the first 48 hours, and then for the maintenance of 5 grams once a day. The 5 gram once a day maintenance, we have just now published a database for about 200 patients that we were able to optimize from the cardio-renal clinic, where patients with hyperkalemia were coming back again and again, especially when we are trying to optimize their ACE inhibitor or ARNI kind of drugs. But Lokelma has definitely helped us to optimize the patient's four pillars, especially the ARNI and the ACE, because it keeps your potassium in a happy range. The harmonized trial, which was for 11 months on this drug, showed that majority of the patients, 88% of those patients on the trial, were able to keep their potassium less than 5.1, and that meant that we were able to optimize the four pillars as much the patient's blood pressure could tolerate. So amyloid is again a very interesting thing. We see in some of our patients, we know cardiac amyloid can affect the heart, whether it be light chain AL or TTR amyloid. It can get deposited in the heart and can affect the heart function. This is the pathogenesis, that there's chronic inflammation, macrophages activation, which leads to AL and AA protein, which is again an abnormal number of excessive protein that you start producing. But also there is another variant, which is the mutant protein that leads to ATTR amyloid. And again, we have seen quite a large number of these patients in the last, especially I would say in the last 5 years. So again, these are some of the red flags that you should be aware of. If you have a heart failure patient with LV wall thickness of more than 12 millimeter, these are, and plus one, any of these red flags, definitely think of amyloid, because again, 12 millimeter LV wall thickness, any of these red flags on the slide is likely to be an amyloid patient. So again, patient with heart failure more than 65, aortic stenosis, hypertension, decreased QRS, AV conduction disease, pseudo Q waves of the ECG, subendocardial LG enhancement that you can see on the MRI, or neurological symptoms like ruptured biceps tendon, carpal tunnel syndrome, sensory involvement. So again, all of these, if you have got any of these features on top of your 12 millimeter thickness on the LV, this is a red flag for a possible amyloid, because this is how we use our hidden clues for diagnosis for ATTR. So again, patients above 65, as I said, patients who are not tolerating heart failure therapies properly, patients who have got QRS on the ECG is quite wide. They have got carpal tunnel syndrome. There is excessive LV wall thickness on the echocardiogram, which cannot be explained by a normal heart failure scenario, or they've got autonomic nervous system dysfunction. So again, hidden is something that we use quite often just to pick up these red flags. As I said, that this is again things that you see on the ECG, on the echocardiogram, on the CMR, looking for subendocardial late GAD enhancement or elevated T1 values or increased extracellular volume or abnormal GAD kinetics. So again, some of those things that you should be looking for on ECG, echo, and CMR to diagnose an ATTR cardiomyopathy. So when it comes to management, holistic approach again is very, very important. Obviously, you need to get your four pillars in as soon as possible, because that is the way forward. Four pillars is extremely important. But we always forget about the fifth pillar, which is the cardiac rehab, because there is again huge evidence now that patients who exercise are able to keep themselves more active, they do better long term. The European Society of Cardiology now says that every adult should be doing at least 150 minutes of moderate intensity exercise to prevent long term cardiovascular problems. So, again, this is, I think, one of the most underutilized medication in our clinics, because we normally don't talk about with patients about the amount of exercise that they do. So, again, moderate intensity exercise is something that makes you slightly breathless. 150 minutes of moderate intensity exercise is extremely important. Again, apart from that, having a holistic approach, looking at their lifestyle, their weight, their cardiac function, looking at their lipid profile, blood pressure, glycemic control, all of them are extremely important when you're seeing these patients every 3 to 6 months. MDT is something that we do every Tuesday and Thursday. And as part of the MDT, we have a dietitian, we have a heart failure nurse, occupational therapist, physiotherapist, pharmacist. They all play very important role, because again, a pharmacist can come and tell you what are the drug interactions. A heart failure nurse can help you to optimize those medications in the community. A dietitian can help you decide on your right strategy. A physiotherapist again has been a very helpful resource in the MDT, because again they help with right cardiac rehabilitation for these patients. And again, in some elderly patients, occupational therapists play a very important role. So again, there is a big role for MDT. MDT is almost done for every patient that we have in heart failure. Everyone goes through an MDT so that we can give the best long-term outcome. A GP, heart failure cardiologist, not the only one, but like as I said, that there are lots of other people involved in the MDT, as you can see in this slide. A dietitian, psychologist, physiotherapist, nurse specialist, they all play a very important role. But I think heart failure nurses play a very important role. If you ask me, almost we manage two-thirds of London's population through our hospital, because it's a university teaching hospital. We got 4 district general hospitals that are connected to us for heart failure. We are one of the biggest heart failure centers in the country. In fact, the first heart failure unit in the country to have an inpatient setup. So heart failure nurses play a very important role. We now have a setup every Tuesday and Thursday that we get heart failure nurses to go out and see patients in the community. They present these patients like a case scenario. About 10, 20, 30 cases are discussed. Patients who are having problems with optimization, low blood pressure, falling kidney function, device problems, shocks, whatever those problems may be. So again, heart failure nurses are a big support system for heart failure in the community. So again, looking at some of those studies, this is fantastic. Strong HF that came out last year, that if you're able to optimize the 4 pillars within the first few weeks of the patient getting discharged, the chance of hospitalization, CV death, all cause death goes down up to from 14-16% to 44%. So again, the hospitalization, death, and long-term morbidity mortality goes down drastically if you're able to optimize the 4 pillars in the first few weeks of discharge. So again, that is a very important message. Again, all these trials, I'm sure all of us are aware of the Emperor, Deliver, Empagliflozin, DAPA trial showing long-term better CV outcomes, MACE in heart failure hospitalization. Semaglutide, again a drug that is used in diabetes and weight management, has now shown that it has got effect on heart failure, especially heart failure with preserved ejection fraction, with their symptoms, with their long-term BNP coming down. So again, an exciting news for patients with heart failure with preserved ejection fraction. This is again the FLOW trial, which showed that semaglutide had showed consistent CV benefit across spectrum of kidney disease. So chance of heart attack, stroke, CV death, they all went down by 18% across eGFR in the KDIGO classification. So again, an exciting news for patients who are being treated for diabetes with semaglutide or for obesity. This is again a paper that came out only last week. This was a paper suggesting that there are lots of things that we do with patients in heart failure and obesity. Diet is one of them. Anti-obesity medication is one of them. But again, these drugs, these things are again sustainable, non-sustainable. You have to decide depending on the class of patient, the type of patient that you're looking after. Some patients are resistant because in spite of the fact that you try and bring in everything that they want to bring in their diet or exercise, they still don't respond. Some anti-obesity medications, obviously, they do help you, but the moment you start getting on weight. Most of these studies, again, recently published, show that metabolic bariatric surgery has a sustainable long-term impact in these patients to come off, because again, we have seen a lot of patients with atrial fibrillation, for example, who had an ablation done, but because they are obese, they kept going back into AF. So again, and once they lost weight, they became better, and then again, long-term outcome was better in these patients. Fine Heart study, a meta-analysis on finerenone on cardio-kidney metabolic conditions showing better long-term mortality, CV, MACE outcomes in patients when Finerenone is used. Again, patients have been put on SGLT2 and GLP1 at the cardiometabolic clinic. We do get patients who are diabetic, obese, they are suitable for, and again, they have a heart failure, obviously. So they are suitable for an SGLT2 and a GLP1. And we have used these drugs together in many of our patients. In fact, we have managed to take away almost 7 to 9 of those patients, 23 patients from the bariatric surgery clinic who were referred to the clinic. They are off the bariatric surgery list because they have lost more than 10-15 kilograms in weight because of the fact that they were on an SGLT2 and GLP1. So again, these are some of the drugs that we have to be using more and more. This was published in the last 48 hours suggesting in patients with CKD and type 2 diabetes, a combination therapy of finerenone with empagliflozin led to greater reduction in the albumin creatinine ratio. So again, using SGLT2 with finerenone did a better job compared to them using individually. And this is something that has been published in the last 48 hours. This was a confidence trial at the ADA, the American Diabetes Association meeting that happened a few days ago. So again, in summary, I think there are challenges. These are a very complex group of patients. As we know, the importance of four pillar is extremely important. There should be no patient going out of your clinic where they are not on the four. There has to be a reason why a patient with heart failure is not on the four pillar. So four pillar is something that will prevent their hospitalization, long-term outcomes, long-term CV death. MDT, they play a very important role in leading to long-term improvement in their outcomes, trailing the management of the drug depending on their blood pressure and their kidney function is extremely important. Managing all those complications and comorbidities that we discussed with a holistic approach is something very important as well, because for example, in our cardio-renal metabolic clinic, we don't only just try and optimize their medication or refer for an echo or an angiogram or an MRI. We also try and give them gym passes, physiotherapists, psychologists. We do all of those things that is required. The moment a patient walks in, we do a full MOT. MOT means trying to manage the patient in every possible way. We don't leave anything for the primary care or for the GP to do, because we try and do everything possible for that patient in that same clinic, and that is what will help them long term. So thank you so much for listening to me, and I'll be very happy to take some questions.
So, thank you very much, Dr. Rajay. This was an excellent deliberation, and I will just check and whether there is a question from Dr. Neha Kumari. She has been very proactive in learning and asking questions. Few words about learn to unhealthy paradox in cardiometabolic setting.
Sure, I can see the question from Dr. Kumari, Dr. Neha here, that she's asked what difference between cardiometabolic risk factors in rural and urban population in India, and what about the cardiohepatic syndrome? Absolutely, very good question. But as I said, that majority of the patients that we see in our setting, in our clinic, obviously cardiohepatic, MASH, NASH, whatever you call it, it is obviously one of the syndrome that is now being recognized more in metabolic syndrome. We are seeing many of those patients with liver issues as well. But the main long-term outcome, hospitalization, CV death, MACE, all that is mainly affected from your kidney function, from your heart function. So again, unfortunately, cardiorenal still is the main challenge that we've seen in these patients. MASH is something that obviously if you try and get these patients to lose weight, if you control their diabetes better, then obviously the MASH, NASH, all that will also respond at the same time. But I think more importantly, heart and kidney remains one of the biggest challenges that we see. There is another question, Dr. Sinha, about diagnosing heart failure correctly. Is echocardiography the most reliable test? Absolutely. This is a gold standard test because MRI will not be available, especially if you're seeing a patient in urban, suburban area, because MRI may not be available. Echocardiogram is key. But at the same time, you have to be very good in echocardiogram because you need to pick up those patients who may have good systolic function, but they have problem with their diastology of the heart. So again, looking at all those parameters is also important for diastology of the heart. But the gold standard now in the community that is being used, because again, there is a long waiting list for echocardiogram in the UK as well, whether it be a district or a university general hospital. I think BNP as a blood test is being used more and more in the community to diagnose heart failure early.
Lean but unhealthy paradox. That is the comment by Neha Kumari. Can you
Correct.
comment?
Absolutely. I agree, Dr. Neha. You are absolutely 100% right. I'm not saying that we are not going to give it less importance to NASH and MASH. But what I'm saying is that, again, there is emerging data now. We have understood about liver problems more and more in the last 5 years now, I think, from the studies. But heart and kidney obviously is in the forefront when it comes to CV death from these in these patients.
Yeah.
There's
Some
some mention
comment.
starting beta blockers with diabetes because it masks the hypoglycemia. Sudden stopping of the beta blockers can precipitate arrhythmias. Not necessarily. If you look at some of the trials from coronary artery disease side of things, because we use extensively beta blocker in CAD, and again, some of the trials recently showed that once beta blocker was stopped 12 months after an ACS event, their long-term outcome was similar to the patients who were on beta blocker or not on beta blocker. So again, post MI, having beta blocker long term, obviously in patients who have got low ejection fraction, who have got arrhythmias, who got AF, you absolutely 100% they have to be on beta blocker or any other antiarrhythmic drug that is required. But more importantly, in straightforward coronary artery disease with no underlying fibrosis, no underlying precipitant for an arrhythmia, beta blocker obviously is a fantastic drug because it works like a nice mobile and engine oil for your heart because it reduces the amount of blood that the heart requires to function and pump. So again, a very, very important drug to have on board 100%. It is one of the four pillars for heart failure when it comes to heart failure. But again, when it comes to coronary artery disease, there is again evidence to suggest that not necessarily that has to be carried on for life. But again, these are all emerging evidence. We'll have some more in the months and years to come.
Yeah. So this was a very, very
One more
elusive,
question
illustrative
is there, sir.
talk by Dr. Rajan Narayan. And the most important thing which I learned was if you optimize therapy for heart failure, probably you can avoid CRT, a device which is very costly. This is
Correct.
true in India. So that's a very important issue we should remember.
I can tell you, Dr. Sinha, that I've had at least 50 patients in the last 5 years where we have switched from an ACE inhibitor to an ARNI and optimized the drugs further, all the four pillars. I've referred that patient to a pacemaker cardiologist that this person's ejection fraction is 33% after 4 months, but at the same time switched on their ACE inhibitor to an ARNI, to an Entresto, to Vimada. By the time the patient reaches the pacemaker doctor, ejection fraction is above 40% or 37%.
Doesn't do any
It doesn't need the
CRT.
device anymore.
Yeah. That's the message we should carry. All those talented PG students and doctors with
So-
me, with us.
Sorry
Yes.
to interrupt, sir. One more question.
Sure,
We
Dr.
missed in
Muhammad.
the
Yes, please go on.
chat box. We missed a question in the chat box. It says,
Sure.
to diagnose heart failure correctly, is echocardiography the most reliable test?
I would say that 100% echocardiography is the gold standard because again you won't have MRI in every hospital everywhere. In fact, in UK also in majority of the hospital, in district general hospital, we don't have facility for MRI because we have very limited imaging doctors. But echo is something that obviously it's a gold standard. As I said, that it can help you not only because BNP will be raised both in systolic and diastolic heart failure. BNP will not tell you whether this is a systolic or diastolic heart failure. What will tell you what his ejection fraction is, what the valve problem is, if there's a pericardial effusion or pleural effusion, all those things that you will see on top of systolic or diastolic heart failure is an echocardiogram. So absolutely 100% a good echo is very, very essential for heart failure diagnosis.
And
Thank you, sir.
secondly, as Dr. Rajesh said, we must remember kidney. And even if your creatinine is normal, USCR is very, very important
Absolutely,
investigation.
100%. You know, Dr. Sinha, in the cardio-renal clinic that we started in 2015, we see a lot of these patients with EGFR around 18, 19, 20. If you don't optimize these patients properly, if you don't bring in an SGLT2 or a finerenone, if they're eligible for finerenone, or increase their ACE inhibitor or RNA therapy, whatever they're eligible for, you will see that the moment you optimize their ACE inhibitors, the moment you bring in an SGLT2, you can delay. In fact, the empagliflozin trial showed that if you start a diabetic patient on an SGLT2 in their 40s, you are likely to delay the dialysis by up to 13 years. That was the empagliflozin trial. The Empire Rec trial showed that dialysis can be delayed by up to 13 years if you start, not in heart failure, just in diabetes patient. If you start an SGLT2 in a diabetic patient in their 40s, the chance of dialysis, going on dialysis, is delayed by up to 13 years.
So message which Dr. Raja has given is, even if your GFR is reasonable, you must do USCR.
Correct.
Try to find
Because-
out microalbumin in the urine. And
Absolutely, because EGFR up to 15, you can use an SGLT2 because there's no evidence, no research. Although there is some primary research happening at the moment in some patients with dialysis on an SGLT2, but the current license, the current guidance from ESC is that you can only use it up to EGFR of up to 15, 1-5.
Yeah. And fifth pillar he has clearly mentioned is coming up very with a force is semaglutide. So we all should remember about semaglutide, although there are some ifs and buts, but this is a very good drug for population of diabetes, obesity, and heart failure. And this has been found very, very effective in all those conditions. Easily available now. Injectables are available across the country now. So we must remember that. So injectable is GLP antagonists are available now in our country. So that's we should remember. So thank you all. Thank you very much. And this is the end of our program for PG and junior doctors. And we are going to have the examination as suggested by Dr. Tiwari, our dean, sometime in July. So thank you all very much. Thank you, Rajay, for your extensive erudite deliberation, and thank you the life sciences three dot life sciences people who have given continuous support to me, and they have never rejected my proposal of keeping some moderator or something. So thank you all very much.
Thank you so much, Dr. Sinha. Thank you, Epea. It's been a pleasure.
Yeah. Thank you. Bye-bye. Bye.